Cancer of the prostate is very treatable in the early stages, but also typically asymptomatic. It is usually diagnosed with routine screening. Diagnostic testing is needed because it presents with the same symptoms as BPH. To diagnose prostate cancer for labs, they can do a PSA or a PAP. They can do a digital rectal exam, and that is going to be positive if the prostate is hard, nodular, and asymmetric. It's important to remember that with BPH, it was symmetric. They can also do a biopsy to confirm the diagnosis after a positive PSA and or digital rectal exam, a bone scan, an MRI, or a CT. Screening recommendations for prostate cancer. The average risk general population male who is expected to live at least another 10 years should start getting screened at age 50. Men who are African American and or have a first-degree relative who was diagnosed before age 65 are considered high risk and should start screening at age 45. Men who have more than one first-degree relative who was diagnosed before 65 are considered an even higher risk and should start screening at age 40. So essentially, the higher risk, the earlier the screening should start. And here are your prostate cancer risk factors: older than 50, family history, African American, exposure to chemicals and pesticides, a diet that's low in fruits and vegetables, and a diet that is high in red meat, high fat dairy, and processed meat. Treatment options for prostate cancer include a prostatectomy, cryotherapy, radiation, chemo, or androgen deprivation therapy, which we will talk about individually. For prostate cancer, the patient can have a radical prostatectomy where everything is removed, or a nerve-sparing prostatectomy where the neurovascular bundles are spared and remained untouched. So with a radical prostatectomy, the prostate and the surrounding structure, so all of those neurovascular bundles are removed. With this procedure, the patient will have an incision in their lower abdomen or in the perineal region. If they have a perineal incision, they will be at a much higher risk for infection due to the close proximity of the incision to their rectum. With a nerve-sparing prostatectomy, the prostate is removed, but the surrounding neurovascular bundles are remained untouched. These neurovascular bundles maintain erectile functioning, so this reduces the risk of erectile dysfunction. However, to be an option, the cancer must be limited to only the prostate. So if the cancer has spread, this is no longer an option. They have to do a radical prostatectomy and remove everything. With a cryotherapy or a cryoablation, they use liquid nitrogen to freeze the tissue to kill cancer cells. For radiation options, we can do external beam radiation or brachytherapy. So with external beam, the frequency of that is going to be 5 days a week for 4 to 8 weeks. And this is going to be done in the clinic. And there's a ton of side effects that you can see listed here. For brachytherapy, it's much more convenient for your patient. It's a one-time outpatient procedure. So they come in one time to have a radioactive seed implanted into their prostate, and then that's it. They're done. However, this can only be done if the cancer is not super advanced. The benefit of it is it's more convenient and it typically has less side effects. Chemo can also be used to treat prostate cancer, but it's only used in late stages when the cancer has been unresponsive to other treatments. Androgen deprivation therapy is another option to treat prostate cancer. Androgen deprivation therapy, or ADT, deprives the body of androgens. Androgens are hormones like testosterone. For prostate cancer cells to grow, the cells need androgens. So ADT can be done with medications or surgery to deprive the body of androgens to prevent prostate cancer cell growth. Like we said, ADT can be done with medications or as a procedure. The first medication is androgen synthesis inhibitors. and those are going to stop androgen production. Next, we have androgen receptor blockers, and those medications will block androgen receptors. These do all have a common ending of TAMIDE. And last on this slide is the procedure. Your patient can have an archiectomy, which is the surgical removal of the testicles to stop production of androgens like testosterone. This is the gold standard for ADT. All of your ADT treatments that we talked about on the last slide, so all of the meds or the procedure, do have the same side effects because ultimately they're doing the same thing. They're blocking the androgens. So our cardiac side effects are going to be high cholesterol, high triglycerides, CAD. Musculoskeletal side effects will be things like osteoporosis, bone fractures, and loss of muscle mass. And the hormonal side effects will be things like hot flashes, gynecomastia, low libido, and weight gain. Testicular cancer is usually rare and easily curable, but it does have a high risk for infertility. Your symptoms for testicular cancer are going to be a painless scrotal lump, a dull ache in the lower abdomen, or scrotal swelling, heaviness, or a dull ache. To diagnose testicular cancer, they will palpate for a mass. A cancerous mass will feel firm, and it will not transilluminate with a flashlight. So what transilluminate means is light will not shine through. They can also do an ultrasound and tumor markers. Treatment options for testicular cancer include chemo, radiation, and orchiectomy. Erectile dysfunction, or ED, is the inability to attain or maintain an erection. Risk factors include aging, spinal cord injuries. Sometimes it can have a mental component like stress, anxiety, or depression. Substance use, nicotine, alcohol use, also prior urinary surgeries or conditions. Sometimes this is a side effect of medication. We see this a lot with antihypertensive meds and psych meds. So do educate your patient to tell you if they're experiencing this. That way you can change their meds and try something else that hopefully won't have the side effects. Or sometimes we see this with other disorders like diabetes, hypertension, vascular diseases, or other conditions that affect cardiac output, because ultimately this is a perfusion problem. The treatment for ED includes counseling, medications. The medication that we use is a PDE5 inhibitor, and there are also different devices. So ED is treated with PDE5 inhibitors, and these PDE5 inhibitors relax the smooth muscles and increase blood flow. Your side effects are going to be headache and flushing. These meds do all have a common ending of AFIL. You do need to educate your patient to call the healthcare provider for an erection lasting longer than 4 hours, and also teach them not to take these medications with nitrates, because nitrates increase the risk for hypotension and their blood pressure could bottom out.